Wow. Okay. Well, thank you all for having me. My name is Robert Pettis. I tell you just a little bit about where I came from, and I do a lot of my surgeries at Hoag Hospital, but I'm also on the faculty at UCLA in the Department of Otolaryngology, and I trained at UCLA. I went to med school at UCLA as well. Went to undergrad at UC Berkeley. Grew up in California mostly. Was born in Dallas, Texas. And I got into medicine kind of in a roundabout way. I was actually not planning on doing what I'm doing now until about age 22. I didn't follow the typical path where, nobody in my family is really in medicine, but and I never really thought about medicine as a career. But when I was 22, I found out I had an acoustic neuroma, which is a benign tumor of the acoustic nerve on the left side. It was a big tumor, about 6.5 centimeters at the time when it was discovered, so it was actually categorized as enormous. And that experience, getting the surgery and recovering, I have a left-sided facial weakness now because of that, has really kind of got me to thinking about a career in something else. And I developed a relationship with the surgeon, Bill House, who just actually passed away earlier last year, but pretty famous head and neck neurologist who took it out. You know Bill House, yeah. Only 2 or 3 guys in the world probably are really good at that. Ugo Fish is another one, and a guy named Robert Jackler at Stanford. Another one named Daryl Brackman at the House Institute. Anyway, so that relationship that I developed with Bill House kind of really got me to thinking about medicine, a career in medicine, and that's why I'm here now. I was actually, sort of on the course to becoming a teacher. I was getting my teaching credential at UC Berkeley at the time, and I was able to kind of still stay in academics to some degree, and I feel like while I didn't have a cancer, I did have something go wrong with my body. So I'm familiar with that, since that thinking, that thought process. Anyway, so let's get started here. It seems like I'm sitting amongst people that have dealt with head and neck cancer. So this is a really tremendous honor for me, because I don't usually get to see this side of people. I see you in the office and treat you in the office, but thank you for having me, and I'd like this to be an open forum, so please stop me anytime. All right, so I'm just going to try to talk about a lot of this. You probably know all of this. What is cancer is a surgeon's perspective, and the different types of cancer in the head and neck. So I guess the dominant theory for the last 4 to 5 decades on what cancer is really the clonal evolution theory. This was proposed in 1976. And basically the clonal evolution theory states that cancer cells, when they become cancer cells, they have to start from something. So they start from normal cells, and they sort of meet. Our DNA is mutating millions of times a day. We have DNA reparative mechanisms that are supposed to fix that. Sometimes we don't catch everything. So a few DNA mutations sneak through, plus we're bombarded by environmental assaults, which can mutate our DNA. Environmental meaning diet, external beam radiation. Every time you go up in an airplane, that's external beam radiation. There used to be those Buster Brown shoe boxes that we would look into to size our feet. So there are lots of external beam radiation sources or mutagenic sources externally. So those cells that sneak through our body's defense mechanisms and our reparative mechanisms sort of start to proliferate in little tiny clonal populations. Certain clonal populations may be able to increase in number just to the extent where now they're in the thousands or tens of thousands of cells, and then beginning to crowd out other mini populations. That dominant clonal cell population gets big enough where it suddenly develops the ability to differentiate and mutate amongst its clonal population, so that it's taken a series of mutations to get to that point, that clonal population, and then it begins to sub-differentiate from there. It begins to be able to learn how to fight through cell barriers, like layers of fascia, or it learns how to infiltrate into nerves, or it learns how to infiltrate into nodal tissue, or adjacent tissue. So when that dominant clonal cell population develops the ability to spread, that's sort of that critical moment where we think where cancer becomes cancer. And then at that point, the tumor just continues to invade. So when I look at a patient who has a tumor or something that's been proven to be cancer, the first question that goes through my mind is this resectable? Am I going to be doing something good? Is there a potential for cure? Part of that answer involves looking at the nodal disease. And as we'll see a little bit later in this talk, in the head and neck, you can have cancer involving many different places. We call them subsites. So each subsite has different chances for spread to the lymph nodes in the neck. Usually cancer just doesn't pop up in a random place in the neck. It'll pop up in a subsite first and then spread to the neck. So if we see a patient with a big neck mass, that's probably a lymph node that's swollen up with cancer cells. The question in my mind is, where's the primary site? Where's that coming from? Sometimes you don't find a primary site, so you've got an unknown primary. That's a whole other can of worms. Any questions so far? So anyway, I also take into account the overall health. If somebody's going to be put through a huge surgery, I'm sure some of you very well know, you've got to be in relatively good health to begin with. Got to make sure your medications are well understood. If you're on blood thinners, you can't have a big surgery, so we've got to manage the blood thinners. It's really important, I think, to look at preoperative functionality. How are you doing preoperatively? I mean, most people are doing okay, although they may be losing weight because of the cancer. Preoperative functionality, speaking, swallowing. Sometimes, though, with a big laryngeal tumor, you can't do anything. You're already G-tube dependent, or you may have lost your voice a long time ago. I think probably one of the most important predictors for success, in my view, is the family and social support network that people have. If you don't have that, you're dead in the water, I think. No, I'm sorry to use that language, but really, that is critically important. If you don't have a good support network, that is a very worrisome thing for me. And that sort of ties in with the emotional state. You've got to be ready to fight, I think. There have been lots of books written on the importance of mindset, of attitude, of being willing to fight cancer. And if you're not willing to fight, if you're ready to give up, we don't know why this is scientifically, but or medically speaking, we can't give you a randomized controlled clinical trial showing why or explaining why people with more defeatist attitudes tend to do poor, but they do. People with stronger desires to fight do better. That's just right.
From Houston to Cuba to guys in the animals that just plow through it. I've seen both sides.
Right.
And I've seen I'm not telling you right now.
Yeah.
You can't take the money to fight off the deal, but you need that. You need something to have to get.
Couldn't agree with you more. Firm believer in that too, and I will give people the biggest pep talk, motivation talk I can before we go into a big surgery, and I really try to make sure that the family network, the social support network is optimized before we embark on this journey. So, and then finally, what is the patient want? I can remember one gentleman, he had this huge tumor in his scalp, squamous cell carcinoma, and this was like 2 years ago. He was 94, He had done everything in his life. He was like he was like 6'4". He used to be a model for, I think, a ski company. So he would always go up skiing and get super sun exposure, fair skin. So of course he had field cancerization all over his head and neck skin. Anyway, he had this big, huge tumor and lots of little satellite colonies, and you just have to ask yourself, what's the endpoint here? And the family wanted him to get a huge surgery with a flap reconstruction. He didn't want it, and he was of sound mind. So I really have learned that it's important to listen to the patient. Sometimes it's time to do something different, and I really respect that. But it's hard for me to say that as a surgeon because I'm trained to fight this. I'm trained to operate. Anyway, so those are all the things I think about when I'm trying to do a plan. 4 things I look at when I take out a tumor. First of all, what is it? Is it cancer? Second, if it is cancer, what's the extent of disease? Is it well contained? Is it spread to adjacent tissues, muscle, fat? What are the margins? Did I get all around it? Like if I'm taking out a tumor from the tongue or the tongue base, are the margins negative? That's really critical. And then finally, histologic features. Is it well differentiated, moderately differentiated, poorly differentiated? Those all have really important prognostic indicators for survival. Any questions so far? Is this a good speed? Okay. So, types of cancer in the head and neck. There are lots of cancers that can occur in the head and neck. We can kind of generalize, though. Lymphoma and squamous cell carcinoma comprise 92% of all the kinds of cancers you're going to find in the head and neck. And then there are many, many others. Let's focus on lymphoma and squamous cell carcinoma. Has anybody had any other type of tumor? Was it a tumor of the parotid? Was it like adenoid cystic or mucoepidermoid or? That's the short part is pretty good. No kidding. He's actually meeting me here in about an hour or 40 minutes. What, it was in your parotid gland, correct? Oh my goodness. When did he operate on you? Wow. Did you get radiation?
I have radiation 6 different times throughout the different
Wow.
tumors, and I've had chemo twice.
Wow.
So I really stand for that.
Do you glow in the dark? When was the last time you saw Dr. Shurkars?
In December, I'm seeing him again next week.
And did Dr. Juilliard do your radiation?
And I have the radiation.
Oh, good. How are you doing? Was your last PET CT scan okay?
Yes, and I think there was one lymph node, and I grabbed it and everything.
And they're just watching that lymph node? So they're just watching that lymph node, and it's not growing?
No, not yet.
Good.
So I'm going to talk to Dr. Shurkars about next week.
Good. Wow. Yeah. Thank you for sharing that. That's a good sign, though, that if Dr. Vandermolen wants to watch it, I think that's a really good sign. The lymph node? Oh, you mean the other? Yeah. Wow. Thank you for sharing that. That's an amazing story. So anyway, these are the things that I look at, and okay, let's just keep going here. There are two kinds of Hodgkin's in general, or two kinds of lymphoma, Hodgkin's and non-Hodgkin's. Anybody have lymphoma? Oh, you had lymphoma.
Yeah, that's 13 years, so I had it myself.
Good gracious. Oh my
It's a
goodness.
walking miracle.
Wow.
I told them not to get any ideas with any other cancer sites like urologic. But I also navigate that.
Oh my gosh.
I had 2 chemotherapies, and then I got spinal meningitis, kidney failure,
Wow.
and cancer for my son,
Wow. That's, you've been through a lot.
Is that lymphoma like a blood cancer?
Mm-hmm.
It is blood cancer.
Blood and lymph, yeah.
Okay.
Yeah.
That's what that means.
Yeah. So you're thinking about leukemia. Leukemia is more the blood, and lymphoma is more the lymph. But they both spread by blood and lymph.
And Hodgkin's is just the type. My cousin has Hodgkin's.
Yeah, Hodgkin's is just another kind of lymphoma that can tend to occur in younger. How old is your cousin?
He's in his 60s.
Yeah. Oh, really? So is it probably non-Hodgkin's then? Or does it stay with Hodgkin's?
He said Hodgkin's.
Did he? Really? Wow. You can get Hodgkin's older, but it's unusual. Usually people are younger. They get like the single solitary lymph node above their clavicle. That's like when you're really worried about Hodgkin's. Non-Hodgkin's, you tend to get patients are a little bit older. They tend to have multifocal disease all over their neck or chest, body, and the cure rate's much lower. Yeah. Good. So, usually I don't expect to see people say they have had lymphoma, but we've had somebody with lymphoma here. But getting on to the most common kind of cancer we see in the head and neck, squamous cell carcinoma. Really about 90% of the tumors in the head and neck involve squamous cell carcinoma. And the convenient way that otolaryngologists have divided up and have tried to make sense of where cancer can occur is by looking at the subsites that these tumors tend to occur. So we divide them up by different sites in the head and neck. So oral cavity, oral pharynx, the back of your throat. The larynx, or the voice box, can be divided into 3 levels. The top part of the larynx, the middle part, the glottis, and then the inferior part, the subglottis. Nasal cavity, sinus cavity. The sinuses, of course, are holes that surround the nose. The nasopharynx, which is the back of the nose. The ear bone, the temporal bone. And then finally the skin. And then you can have an unknown primary where you have a big swollen lymph node in your neck. You don't know where the primary is, and you can't find it. Believe it or not, recent studies in the last couple of decades have shown that chemo and radiation therapy for an unknown primary, sometimes when you don't find a primary, patients tend to do better than if you find the primary. Any questions about the different subsites? How many people? I know about you've had parotid gland cancer, and by the way, you can get squamous cell carcinoma in your salivary glands as well. It's a little more unusual.
Yes, if I got it right.
Base your son.
Yeah.
So they've all had the squamous.
Where have you folks had your tumors?
Well, there's a big tumor on my tonsil, I guess is where it is, and then it spread to the most in my neck here.
Have you been treated yet? Have you been treated yet?
No, I'm just starting out. I just done the diagnosis, and I'm scheduled to get the dental work done. I'm scheduled to have a PET scan, a CT scan, and all coming out.
Did you have your tonsils out?
I never have had my tonsils out.
When were you
That
diagnosed?
actually raises the question, is there any statistics as to people who have their tonsils out and have less cancer, or?
It's sort of the should I talk about? Yeah, it's sort of the standard of care to have your tonsils out. Who diagnosed you? Who diagnosed you?
Dr. Iver?
Feinberg. And he didn't do a tonsillectomy?
No, because it's too big, and he doesn't want to operate.
Oh, really? Okay.
You expressed an opinion, right?
And Dr. Nagami up at City of Hope.
You saw Ellie Nagami? You saw Ellie Nagami?
Yeah.
Excellent. She
said surgery was not an option for me too.
She trained at UCLA too, and she's great. She was about 3 years ahead of me. She's outstanding. So, but what did she think about doing a tonsillectomy on? I mean, tonsillectomy is not curative. A tonsillectomy is sort of diagnostic, and we do that to remove the bulk of the tissue. You're still going to get treatment, radiation and chemotherapy. There are two ways of doing it, and really it just depends on your background and what you're trained to do. At UCLA, we're trained to take the tonsils out. That's what we do. We do surgery. We take the tonsils out. There's about a 17% chance of contralateral spread to the other tonsil, so we take them both out. There are three ways of doing this. Either you just do an incisional biopsy in the tumor in the tonsil, or you take just that tonsil out, or you take both tonsils out. We're aggressive. We take both tonsils out. So we want to get the bulk of the disease out, and we want to take the other tonsil out too, just in case there's any micro spread. The other way of doing it is just do an incisional biopsy and leave the tumor behind and let the chemo and radiation melt that away. You can do that.
Well, the question I got is if they want to try and shrink it down before they think about doing any surgery.
Well, usually if it's tonsil cancer, then it should respond. Is it HPV positive, or do you know?
Yes.
That's good. If it's HPV positive, then it should respond pretty well to chemo and radiation. Yes. You're talking really well, so it can't be that big.
Yeah, well, that's a miracle. I mean, I was thankful that
You're talking,
on my vocal cords or down in the larynx. I was wanting them to look at my esophagus because I'm kind of worried I've had some reflux issues over the last couple of years.
Right.
Nobody wants to look at it. I guess it would show up in the PET scan if I have something going on there.
It would be unusual, very unusual for you to have any.
Swallowing okay.
Yeah, I don't. Yeah. How about lumps in your neck?
Yeah, there's a big one right here.
Oh, you sure do.
And they're saying that's metastasizing on the big one in my tongue.
When do you start with therapy?
Well, like I said, I've got the dental appointment at the end of the month, and I expect to start therapy 2 weeks after that or 3 weeks after that because it's got to heal up. And then the PET scan.
What's got to heal up?
The dental work. We're going to pull 4 to 6 of my teeth.
Who's doing that?
Dr. Lowe.
Okay. He's good.
Yeah.
Can't get in to see him any sooner?
Pardon?
Can't get in to see him any sooner?
Well, not really. I've got some other issues, and then he didn't have an appointment, and they're going to call me if there's a cancellation, and I can fit in a little sooner. But
Does he know why you're seeing him? Does he know why you're seeing him?
Dr. Lowe? Yeah.
Okay. He knows
He had appointments sooner available, but I have other things like my girlfriend is going through chemotherapy for cancer too.
Okay.
She just found out about it in the last. She
Sure.
found out about hers before I told anybody about mine.
I see.
And so I was kind of helping her through that. I mean, I just was kind of of the opinion that a couple of weeks here or there isn't going to matter that much, but that.
Yours is pretty.
That was not coming in for 3 years.
I'm glad you're plugged in. I'm glad.
For me, this is taking action. I mean,
Good.
I'm going to do it.
Good.
So.
Good.
Actually, she had given me your name, and I had pulled an article out of the newspaper in the register. I read all about you. I was so impressed with your story and everything. But you weren't in my network of insurance.
Oh no.
So.
Oh gosh.
That's.
That's how you make decisions.
Yeah, that's bad. That's really sad.
But Dr. Feinberg seems to be a real good guy.
He is. I know him really well. He's a good guy. He's a good guy. And I'm glad to see that you're plugged in. You need to get in and get that therapy.
Get started.
Yeah.
My goal is to start no later than the third week of April.
Did you have any trouble with Dr. Lowe's a great guy. He's one of my favorite guys to work with. Just let me know. Feel free to call me.
Well, actually, I was going to kind of think of you as kind of somebody maybe I could go to as a second opinion consultant.
Absolutely.
And so that's definitely on my mind.
Okay. But good. I'm glad you're here, too.
Has the thinking changed about surgery versus non-surgery? Are they, the way we understand it, they're trying non-surgical for a lot of times now versus disfiguring or disabling.
The thinking has changed a lot.
Hasn't it changed in the last 5 years?
Actually, really 8 to 12 years. In 1997, 98, 99, there were a series of really important studies. First, there was a VA study at the West LA VA that looked at combination chemo and radiation therapy for bladder cancer and advanced cancer of the head and neck. And then there were the EOR-TC trials in Europe, which looked at different combinations of combination chemotherapy and radiation therapy. Basically, in a nutshell, what came out of these really important studies was a new way of doing combination chemotherapy and radiation therapy. We've been tinkering for decades on different doses of radiation, 5,000 rads, 7,000 rads, 8,000 rads, 6,000 rads, 6,500 rads, and then different chemotherapeutic agents. Do you give the chemo first, followed by radiation? Do you do them both at the same time? Do they overlap? If so, how much? Well, we're getting better and better. I should say the oncologists, the radiation oncologists and the medical oncologists are getting better and better now at fine-tuning the combination and how they deliver the chemotherapy and the radiation therapy. And in my recent, very brief experience, I've only been out of training 6 years, 7 years, and things have changed a lot since then. I can remember as a fourth-year resident, you had a tonsil tumor that extended to the tongue base. Automatically, you got a commando procedure or a composite resection. Now, more and more, we're using chemotherapy and radiation therapy. UCLA is a pretty big cancer, head and neck surgery cancer center. We do a lot of tumors there, and we're very surgery-oriented. And probably one of the most surgery-oriented programs in the country. And we're just now starting to back off from that.
Do you work with Dr. Adammeyer?
Oh, yeah.
He's a good business.
He is. I mainly, work with Dr. Surkars, Adammeyer, Dr. Blackwell, and we're still pretty aggressive, but we're now beginning to trust the medical and the radiation oncologists a little bit more because the results speak for themselves. And there's a lot to be said for organ preservation. There really is. I think if I had a tumor, I'd really think about, knock on wood, but if I did, I'd really think about organ preservation at this point.
Versus automatic surgery.
Yeah.
Mm-hmm.
Yeah. So,
I got to meet the pathologist here, which was kind of very nice. With my path report, I went down and she showed me my slide of, that your cancer cell on your computer. It was pretty interesting, actually. We don't really know if you do this, but and she said, this is why I don't do a lot of surgery because you miss one of these little chemicals. It's in your lungs.
right.
So they didn't do surgery.
It's really interesting to me hearing how different people in the community have had treatment. At UCLA, we take out the tonsils. Yeah.
Just out of curiosity, now, does that mean then that everybody really should have their tonsils out at a young age, theoretically? Or?
That's a really good question. No.
I first thought, go away and just gonna shove it in primary somewhere else, and then come home and start taxing them.
There really is no great answer for that, but the good answer is no, because tonsil cancer is a rare event still. Although we are now seeing a rash of HPV-positive tumors in the head and neck. There are different theories about why that is occurring, but no, for unless you've got recurrent adenotonsillitis, more than 3 to 4 episodes in a 12-month period, or even 6-month period, 6 to 12 months, 4 to 6 in a 12-month period, then the current standard of care is to watch. We really back off on taking tonsils out of everybody. Now I think the pendulum is just starting to swing the other way, because for a while there we weren't taking tonsils out of anybody, but now we're beginning to do it more again.
I mean, even for people that have had their tonsils out, they can still get a lot of cancers in the head and neck, but they don't get tonsil cancer.
Oh, sure, you can get tonsil cancer.
With your tonsils out?
Oh, yeah. Yeah. There are different ways of taking tonsils out. There are some surgeons that just sort of slice the top of the tonsil out, and there are other surgeons that do a comprehensive tonsil resection in the correct plane, getting all the tonsillar tissue out. Believe me, I've seen lots of really different tonsillectomies. So we call it tonsillar regrowth, and it's not really regrowth, it's really persistence of tonsillar tissue that was never taken out to begin with. So, yeah.
If you had head and neck cancer, but not of the tonsils, after your treatment, should you have your tonsils out as a proactive?
That's a really good question. The answer to that, as far as I'm concerned, is no, because second primaries are rare. Second primary cancers are rare, and an adult tonsillectomy is a hit.
I know.
You don't want to do that unless you really, really need to. And that also sort of, answers your question. You got millions of people needing tonsillectomies if we want to take tonsils out of everybody, but then you've got thousands of different head and neck surgeons taking them out differently. Some leave tonsillar tissue behind, others don't. So what's the point? So really, no, we don't do prophylactic tonsillectomies. But if there's an indication for doing it based on recurrent tonsillitis or tumors, then yes, absolutely, get them out. Get them out. The staging system you all already know about. And by the way, I don't have that many more slides. Let's talk about whatever you want to talk about. But basically, staging is based on the T&M system. This is all boring stuff, but basically stages 1 through 4. If you've got lots of nose in your neck, you're stage 3 or 4, and that puts you into a different prognostic category. Yeah.
You said I had 2 T2s, which equated to like a 4A or something like that.
Right. So where was your initial tumor?
What I said primary was
tonsil. Okay.
And then the salary was a little bit long on the neck. I was down one day. It's like, what in the heck?
Right.
I was here in like 20 minutes.
Right. So basically,
I was getting an ultrasound within a half an hour.
I'm sure.
And
Yeah.
some things I procrastinated on that day. I didn't.
Sure.
So I don't know. Then I had T2 or
Yeah.
T4. What?
So check it out.
How does that work?
So the staging system really depends on the T mostly, but then the N and the M come into play. What I mean by that is the T corresponds to the size of the tumor.
Okay.
Sounds like you have a big tumor. If yours was a T2, here's how we define T. T1 is 0 to 2 centimeters. 2 centimeters is about that big. Maybe a little bigger. Yeah. T2 is 2 to 4. T3 is 4 to 6, or beyond 4. pretty big.
So now the combo goes together.
So if you have a T1, then you're stage 1. This is, let's say you've got a negative neck, no nodes in your neck. T1, stage 1. T2, stage 2. T3, stage 3. If, though, you have a Goomba in your neck, a mass in your neck, you're automatically stage 3 at least. Yeah.
Stage 4.
Stage 4 is what goes beyond the neck then?
Stage 4 is you got masses in both sides of your neck, or you got distant necks. You can subdivide the stages, and then it gets kind of complicated. If you're stage 4, you're stage 4. Yeah. That's advanced disease.
Wow.
That's advanced disease.
I just happened to look in the mirror while I read light one day and going, I didn't turn my head and all of a sudden I'm like, what in the world?
That maneuver you just talked about is critical. As if we ask patients to turn their necks, that brings out their lymph nodes a lot more.
Yeah.
Can't tell you how many nodes I've caught doing that maneuver.
You didn't see the time saying I'll get up at 5 in the morning and shave and clean up the room in the office. No, I didn't see it. I mean, I turned my head and down my neck and all that. And I actually felt it before I saw it. Just happened to come in the other way. And I looked.
That's how a lot of
I was in the parking lot. I'm like, what in the world?
yeah.
Gone. Took a half a golf ball. And you turn your head the other way, gone.
Right.
So,
Right. That's a very common, not uncommon way of people finding out.
and it felt great.
That's good to know.
I mean, I was 240, I was a little over.
Oh yeah. Cancer doesn't hurt. Cancer doesn't hurt.
I didn't feel it at all.
Cancer doesn't hurt. No.
And nothing was going.
Yeah. So there are lots of types of surgeries that we can do. Large local excision, where we just cut the tumor out basically and hope for negative margins. Many times we'll need to do a neck dissection in conjunction with that if there's any concern of spread. And then finally, the other extreme is a big composite resection where we have to take out part of the jawbone. This is sort of just some pictures about what we do in a neck dissection. We dissect out all the critical zones, zone 1 through 5. If it's a big tumor, we really want to clean out the neck as best we can. There are different kinds of neck dissections. There are neck dissections that spare the critical structures like the muscles and the big vein, like the jugular vein and the carotid artery. And of course, the carotid artery is usually left intact. And that's actually one of the signs of non-resectable tumors. If it involves or invades the carotid artery, then we really don't touch it. But if it doesn't, then we can actually take the internal jugular vein. We can take the nerves if the tumor is involving the nerves, like the spinal accessory nerves, controlling the shoulder shrugging, the marginal mandibular nerve, which controls the corner of the mouth movement, the hypoglossal nerve, which controls your tongue movement. Those are some of the key nerves that we look for to either preserve or look for to be involved in tumor. Most of the time when we open up the neck to do a neck dissection, we just see enlarged lymph nodes. Now you have hundreds of lymph nodes on each side of your neck, and they are usually involved in these little nodal chains going up and down your neck. There are different chains of nodes in your neck. There are chains that go down the back of your neck, chains that go down the front of your neck, and chains that go in between. And they go mostly vertical, but also some go horizontally. So you've got all these little nodal chains, and then the nodes along these chains can become enlarged. Depending on the site of the initial tumor, the primary tumor, different chains of nodes can become more or less involved. So, for instance, tumors in the oral cavity tend to spread to certain nodal chains in the kind of the front half of the neck, whereas tumors in the sinuses or nasal cavity or the nasopharynx can tend to spread to the nodal chains in the back of your neck. And we really assess critically the primary site. That's what's so important to find the primary. We assess critically the primary site to then plan any neck treatments. And typically we'll do, a typical neck dissection would involve cleaning out zones 1 through 4, which is basically everything but the very back of the neck. And most of the time we like doing modified radical neck dissections, which basically preserves the internal jugular vein, the spinal accessory nerve, and all other nerves. We don't like taking nerves anymore. About 30 years ago, it used to be commonplace to just take everything. I mean, take the sternocleidomastoid muscle, the internal jugular vein, spinal accessory nerve. In fact, you were considered a, heretic if you didn't take the nerves. If you left the spinal accessory nerve behind, the concern was, wow, you're potentially leaving cancer in the neck. But now, with the advances of chemotherapy and radiation therapy and the surgical technique involving doing a comprehensive, focused, modified radical neck dissection in which you're really getting all the nodal chains out, we find that the results are no different than doing the radical laps. So this is just I'm sure you all are familiar with those who've had surgery on their neck. This is sort of what a neck dissection can look like. This is more like a thyroidectomy incision almost, or like a total air injection. It's not a total air injectomy incision, but this is just an apron neck dissection incision. We typically don't use these types of incisions at UCLA. We utilize the modified Schelvinger incision, which comes down, and these are just two drains coming out.
How much after surgery was that picture taken?
This isn't my picture, but this is probably about maybe 3 or 4 days post-op. She looks pretty good. Not a lot of swelling. I have no idea how this surgery was done. It wasn't minimally invasive. Just look at that incision.
So in other words, this was done like a regular open surgery?
Yeah.
And then, do you see any advantage just generally to lasers, micro-lasers, robotics, and all that stuff as far as?
No. I don't think. You've touched on an area of controversy right now in head and neck surgery. There are certain otolaryngologists now who are using the robot to take out oral cavity and oropharynx tumors. The older school guard, the old guard, thinks this is crazy. They think it's stupid, you're limiting yourself, there's no substitute for getting in there with your hands and being able to control bleeding as it occurs. The robot is this huge hulking instrument that places the surgeon at the other side of the room. And all you've got going into the mouth, you've got a retractor opening and keeping your mouth open. You've got these 4 robotic arms going into your mouth. So the surgeon is looking on a 2-dimensional screen to manipulate these robotic arms to try and resect a tumor. It just seems like a lot of to-do when you can do it a lot more simply and straightforwardly by just getting in there with your hands and taking it out.
So there's a controversy between the two skills?
Well, the controversy involves really being able to assess your margins. The people using the robot now are faced with a daunting task of proving that they can get the same survival statistics as those who don't use robots. And that hasn't been done yet. At least not convincingly, in my mind.
Lasers and the...
A laser is just a tool. A laser is a tool that you can use with a robot or without a robot. A laser can just be brought to a handheld instrument to cauterize. Generally speaking, though, when you're doing a neck dissection or a tumor resection, unless you're doing it using a laryngoscope for a throat cancer or a glottic cancer, which is a different kind of, if we go back to our subsite slide, the different sites that you can have cancer, one subsite that people do use lasers frequently is for glottic cancers and supraglottic cancers. They go to the operating room, they go to sleep, and their nuts are extended, mouth is open, and a laryngoscope is placed in the mouth and throat. and you view the glottic and supraglottic structures, you can usually get a tumor pretty well in your field of view, and if it's completely in your field of view, you can then come in with like a KTP laser or a CO2 laser and carve it out. And generally speaking, the morbidity is a lot lower if you don't make any incisions in the neck. There's a guy in Germany that's doing a lot of endoscopic laser tumor excisions, and Jerry Burke at UCLA is doing them too. Not quite as aggressively, but he's doing them too. And there are different places, a couple of places in this country and throughout the world that are doing more and more endoscopic laser, supraglottic and glottic tumor excisions. So it really depends on the site, whether you'll use a laser or not. For tonsil cancers, typically we don't use lasers. There are some people using the robot for tongue base and tonsil cancers. But why? Because you're going to treat that with chemotherapy and radiation anyway.
So that was going to be my next question. Just generally speaking, if you have surgery, you've still got pretty much the same regimen of chemo and radiation. You don't get more without surgery or less with surgery.
That's a good question that I don't know the answer to. I would have to consult my rad-onc and hem-onc medical onc colleagues. I would think that's not going to make any difference. You take out the bulk of disease. I just like the idea of getting the tumor out. I know there's going to be microscopic disease that you're going to have to chase with chemo and radiation therapy, but I just like getting the tumor out. I like that better. I don't like leaving a tumor behind.
I have a question about tumors.
Yeah.
With the new radiation chemotherapy, it's supposed to destroy the tumor, and Phil's been very fortunate, sounds like you have too, and all of you, and hopefully you as well, that treatment, chemotherapy and radiation, shows the tumor's gone when you do your PET scan. Does that mean it's gone, or can it hide? And can that tumor come back, or if it ever did come back, would it be a new tumor?
Great question. Really hard question. We assume it's gone if you're tumor free for a period of time, maybe a year, maybe 2 years. We have benchmarks: 6 months, 1 year, 3 years, 5 years. These benchmarks are just arbitrary, but we say that if you reach 5-year benchmark, then your risk of getting another cancer is kind of close to being equal to that of a person that's never had cancer before.
In the head and neck?
Right. If, on the other hand, if you're just at 1 year, or let's say 3 years, you're still at an elevated risk of getting a recurrence. So we sort of arbitrarily use these time benchmarks to track where you are in your relative risk of getting another tumor. We think that if you've had a surgery and post-op radiation and chemotherapy, and you look good for, say, 6-12 months afterward, we think the cancer's gone.
What if you haven't had the surgery?
Oh, well, if you've had a post-treatment PET CT that's clear, we think it's gone.
So then they don't...
PET CTs are only, I'm sorry to interrupt you, PET CTs, the limits of sensitivity of our detection instrumentation are not well known. We sort of know, but you're not going to be able to pin down a radiologist and say, and get him to commit. Try. You just, we can pontificate on the level of detection, sensitivity of detection of a PET scan. Basically, we just know that a PET scan measures radioactively labeled glucose molecules, and cancer grows faster than normal tissue. Therefore, cancer metabolizes faster than normal tissue. Cancer needs more energy, more glucose. So it preferentially takes up radioactively labeled glucose molecules, and it lights up on a PET. In theory, you shouldn't be able to see something that isn't malignant on a negative PET. In other words, if you have a negative PET, you should be pretty satisfied that that's negative. But I'll tell you, I have seen crazy scenarios where a PET CT has missed stuff. It's not common. It's unusual. But PETs are pretty darn good.
What would that be related to not having followed the regimen the 24 hours before? I mean, it's pretty...
I mean, a PET scan is pretty standardized. So if you do the PET within the basic structure, it's fine. They're not going to, and they can see the result. I mean, you've got normal tissues that light up on PET, and if they're not lighting up, then you know something went wrong in the PET. Your heart and your brain don't light up.
Different than a PET CT scan?
Yeah, the only difference is with a PET CT, you've got a CT that's being overlaid on top of the PET. The PET scan is just a kind of a blob.
Right.
You know?
Should you be getting a PET CT scan?
That depends. It depends on each clinical scenario. There are certain situations where a PET scan is fine, where you don't need to overlay a CT. So it really is case by case.
We're oncologists.
Yeah.
Which one he's gonna?
Right. And generally, the oncologist should be working in conjunction with a head and neck surgeon.
If you haven't had surgery. I don't think
But if you haven't had surgery, usually that's not the case. They're not working with a head and neck surgeon. Sometimes they are in the beginning,
right.
but then as therapy commences, the head and neck surgeon kind of falls to the background.
Right.
Now, he or she may come to the forefront if you have a recurrent node in your neck. You might need an interval neck dissection. I'm kind of getting off far field here, but I always feel like doctors should talk to each other, and oncologists should interact with surgeons freely. And certainly, I would never feel intimidated, or I would never hesitate if I were a patient to say, could you recommend a surgeon? I'd like to get his or her perspective. More information doesn't hurt. Ever. The more information, the better. And honestly, if the surgeon is doing his or her job, and the oncologist is doing his or her job, they'll get together and they'll talk about it between themselves, and then talk to you about it, and try to present the best cohesive plan. That's a great place to have that conversation. And I'm really kind of excited because Hoag now has got a tumor board for head and neck cancer patients. It's growing. It's every first Monday of every month, in case you're interested. Oh, you come already. Great. And we're growing. And we're actually in the midst of adding another really well-known head and neck cancer surgeon to the mix here at Hoag. And so I'm really excited about that. And this is Dr. Surkars, actually. Excuse me. Hi, Joel. Are you here?
See, that was a question that I kind of have to do with what they were just talking about. Because when I went to the
come on. Are you parked in the cancer center lot?
Either you or somebody in the ministry were talking about they're going to put the TV together.
I'm on the second floor in conference room A. The second floor is
calling, put people together. And is there something I should be talking to you about for this team?
I'm in conference room A. On the floor you walk into, that's the second floor.
Look at my case with a group of doctors and decide what to do.
Okay. How many of you get lost?
Like a definite possibility.
Yes.
So you're going to have radiation here?
See you soon.
Are you scheduled to have radiation here?
Well, yeah, like I say,
Dr. Kim?
I'm going to talk to Dr. Cox and talk to Dr. Sennett. But I mean, I've been kind of contacting everybody based on Dr. Feinberg and your recommendations, just kind of, by the seat of my pants. I haven't talked with...
If you want your case presented at tumor board, then I will talk to one of your physicians and personally ask them to present the case.
Oh, okay. So, I mean, I didn't know if I was outside the group or inside the group or outside the system.
You're always inside the system. There's no system.
Okay.
And I'll usually...
talk to you about where I'm at.
We get to see the cases that are going to be presented. So, let's see. The next case conference is the first Monday.
Okay.
in April. So that's April 1st, I think.
Now, what do they do, the tumor board? Do they look at your case and say, okay, this person should have this X and Y treatment?
Kind of. So we show, first of all, we go over your history. Dr. Feinberg, I guess, is your ENT guy, so he would hopefully be there to present your history. If he wasn't there, I could present it. Then we would show any radiology that you've had, CT scans, MRIs, PET scans, whatever. And then we would show the pathology from your biopsy specimen, the actual slide. And then we'd talk about your case. We would have all the data. We'd have your tumor size, the differentiation from your pathology, and in the room would be head and neck surgeons, radiation oncologists, and medical oncologists. We'd get together and talk about the best way to proceed. Most of the time, it's pretty much going to be the same thing that is being planned for you right now. But it's still a forum, a chance to cull together all the ideas from the different specialties.
Yeah, I mean, it seems like it never hurts to have more than one set of eyes on things.
I agree.
Yes, I agree with that. I went to DCI, I went to the doctor, the doctor went to the house, neither one of us the doctor started on there. That's so much scared because
Interesting. Wow.
yeah, but it was, they thought it was going to sleep.
Well, Dr. Surkars is a very special person. He really is. He's one of the best head and neck cancer surgeons in the country.
Who's that?
Joel Surkars.
He's at UCLA.
Yeah, he's the one that trained me, and I really look up to him. He's great.
And you know what he does when he looks in email? He doesn't buy stuff.
I think so. I think he's coming down here.
Very nice.
He does what? I'm sorry?
He said, trying to change doctor to sign it. He said, that's what he's doing.
Yeah. And he's something else. He's something else. Something else. Yep. Yep. I agree. So, we don't have to talk much about this. This is just for very severe head and neck cancer. We can do a composite resection, which involves surgery in the oral cavity or throat, and we do a wide local resection of the tumor and remove part of the jawbone. And I don't want to show that. I'm sorry. Honestly, guys, I thought this was going to be a room of rehabilitation nurses and physicians. I honestly did not know. I'm delighted that it is. I mean, I'm really, I've never given a talk with this kind of, actually that's not true. I did it once in residency. And it was great. I really enjoyed this forum. So that slide was really more designed to, I wouldn't put it in there. No, yeah, I'm sorry. So another kind of surgery, partial or total laryngectomy, post-radiation / chemotherapy changes can involve severe swallowing troubles, voice troubles, airway protection. There are lots of issues for the recovering patient, as I'm sure you all are very aware. Swallowing is a big one. Anybody have trouble swallowing after their chemo radiation?
Is that what dysphagia is?
Right. Trouble swallowing. Did you have to get dilation?
They were going to, when they did the dysphagia test, they said, well, your epiglottis is probably a little bit maybe firm back there.
Right.
And so they said, you look pretty good, actually.
Right.
And he didn't do that. And with a little nausea from my vocal cords for the second time.
Okay.
Doctor's going to take it off next week.
Good.
So that's why my voice is
Little hoarse.
spreading apart, the story.
Yeah.
So, yeah, I thought it was gone. And my other ENT didn't find it. Talking about a second opinion. My son sent me a Feinberg
I see.
in about 30 seconds. Told him that thing on here and the scope was like, oh, there it is.
Son didn't scope you?
Just through the nasal,
Yeah.
but didn't have $100,000 worth of equipment in the box.
Right.
There it
Right.
is.
Right.
So for the last 7 months, I've been dealing with this, speech therapy and everything else.
Yeah.
So, it's been a little frustrating to say the least.
I'm sure.
I'm on.
Should we talk on the phone for work?
Yeah, talk about things like
Hello?
phones and, you know.
Yeah.
Is Dr. Feinberg an EMT specialist? He's on the...
Are you up front? He's up front. Somebody's coming up to try and grab you, okay?
No, I mean, I think he has all the
What is it? Let's go there.
Come up to the second level.
I mean, I think he's a
So he's a...
Comprehensive or specialist apparently.
the voice and the swallowing.
Yeah, I think that's what you want. Yeah. A gal went out to meet you. I'll see you soon.
Is he here local?
I think so. I think so. I'm not sure. I hope you're in the cancer center.
Website too.
You're not in the. Oh, you're in the conference center. Oh. The cancer center is just right across the street. All right. Yeah. You guys know her name? What was her name? I can't remember either. I'm killing myself here. What was her name? Oh. All right. Well, at least I'm not the only one that forgot. So anyway, so dysphagia is a problem. Esophageal dilation and swallow therapy are things we can do for stricture. For aspiration, that's a tougher one. Generally, you really want to assess how bad the aspiration is. You may have to put somebody on a diet of thickened liquids or thickened foods. The hardest thing to swallow is water. It falls down the fastest. Honestly, if it's severe, you have to give them a G-tube. And in severe situations, when they're aspirating constantly, even on their own secretions, total laryngectomy. Talk a little bit about vocal cord masses and malignancies. There are lots of different masses that can occur on the vocal cords. He's on his way over now. He's in the conference center across the way. So I'm sorry. Malignant lesions involve usually the squamous cell carcinoma, but lots of different cancers can occur in the voice box. Treatment of these can involve a laser or can involve the cold knife, can involve external approach surgeries, and of course voice rehabilitation after radiation and chemo or surgery can often be very challenging. That was really it. I'll tell you guys one really funny story. I actually attended a talk recently by a guy named Pete Pulaski. Pete Pulaski is up at UC Davis. He's kind of made his name recently in dysphagia. Does a lot of work with dysphagia patients. So he sees a lot of patients who have had chemo and radiation in their throat. Hey, there he is. I'm sorry, unexpected guest here. Anyway, this guy Pete Pulaski has this method or this treatment that he's been using on his patients. He's got a few patients across the country that one of them is very well to do, and this patient has actually funded this sort of pseudo research that he's been doing. There's a bone in the throat, in the front of the throat, called the cricoid cartilage. It's actually a bone with some cartilage in the back. And the esophagus is right behind the airway. You've got two tubes in your neck. You've got a big tube in front, which is your airway, and then a thinner tube behind, which is soft, which is your esophagus. Well, people that have had radiation and chemo get a lot of stricturing in the esophagus. And it strictures down, and it becomes really tight. So what Dr. Pulaski has done is he's designed this little hook that he screws into the cricoid bone, and for people that have severe dysphagia after stricture, he teaches them to pull on this hook as they're swallowing. He says, well, at least they can get a couple of sips of martini down. That's, So anyway, it's true. Kid you not, and it works apparently. I'm not sure you'd want to do that every time you ate, though. Anyway. Any questions about anything talked about?
Yeah.